talking Augusta, tell me what is the patient's HAS-BLED score?
Since you can talk.
What'd she say?
What?
We got 3.
How'd you come up with that?
Hypertension. Yeah.
He has hypertension, his age, and then he uses ibuprofen.
Okay. I can see that. Yeah, I agree. Perfect. So what does a HAS-BLED score tell us?
They're at risk for bleeding.
Good, right. So we have a score for clotting and we have a score for bleeding when it comes to AFib. And we can use both of these to help us determine what types of therapy options we're going to use for our patient. Primarily, are we going to anticoagulate them or not based on their clot risk? And do we have to worry about them bleeding based on their HAS-BLED, right? Good. So then, Savannah, tell me a little bit about what counseling points you're going to provide based on this person's warfarin. What kind of warfarin counseling points would you recommend for this patient? Here, y'all, I'm with y'all.
You with me?
Drew, tell me what you're going to counsel on. Use your mic.
An important counseling point is if he's starting on warfarin, he needs to know about any dietary changes and anything that could be potential vitamin K
Good,
in his diet, and also to regularly monitor his INI.
good, good. Any other specific warfarin type stuff? What else did we talk about? Megan, give me another one.
You could counsel them on the signs of bleeding or a thrombotic event.
Good, right? So we gotta teach him what does it look like if you have a clot, what does it look like if you have to bleed. Good. Casey, give me one more.
Stress the importance of notifying all their healthcare providers that they're taking the warfarin, and also to let you know if they're having any type of like dental or surgical procedures.
Good, and why do we want to do that? Why do we want to tell other healthcare providers that our patient's on warfarin? As a pharmacist. Yeah, right? Drug interactions. We're going to talk about that tomorrow. Actually, we have our resident, one of our Savannah PGY2 residents will be teaching drug interactions tomorrow, and we're going to focus on warfarin drug interactions tomorrow. So Casey will hold that point for tomorrow. All right. So this is the list that I come up with when I usually counsel my warfarin patients and I tell them what's going on when their new starts to warfarin. First, I tell them about bleeding risk, so we hit on that. Also, clot risk, we can add to that as well. So if we're expecting that the patient's going to have a clot or they have risk for clot, right, that's why we're anticoagulating them. So we want to notify them, what is your risk of bleeding, what is your risk of having a clot, and what do those look like, and when to seek care. Next, we want to talk about pill color. So we need Savannah here, tell me why we're looking at pill color. Why is that important? For you, smile. Oh, Megan, go ahead.
Different strengths come in different colors.
Very good. Anybody in community pharmacy, right, can tell me that warfarin, even in the inpatient side, right, if you're bringing stuff to the floors, you know that warfarin comes in different strengths. Color correlates with the strength. So every single time, you should tell a patient, what is the color of your tablet? That's a counseling point that's really, really important. So literally every single visit I have with a warfarin patient, I ask them, what color is your pill? What color is your pill? What color is your pill? The reason that that's so important is because we typically, not always, but most of the time we dose in like 5, 7.5, and 10. Not always, sometimes we'll use the other strengths, but we typically use those 3 tablet strengths. So we'll go up in increments of 5 or 2.5. And so it can be very easy that they're taking 2 tablets of 5 milligrams, which equals 10 milligrams. So it can get very confusing. Are you taking a yellow tablet? Are you taking a white tablet? Are you taking a peach colored tablet? What's the colored tablet? And what strength is that tablet that you're taking? Because the strength correlates with the color. All right? So that's a really important piece of information to know to confirm that they have the right tablet strength and that you are thinking in their tablet strength. So you can let them know both what their dose is and the number of tablets. So unlike a lot of most other medications, I usually don't think about talking to them about actually looking at their pills when they pick them up from the pharmacy, because they can have different manufacturers and the craziness that happens. With warfarin, we definitely look at the color of the pill and that specific pill. And it gets a little confusing because some of the colors look a little bit alike. They're just confirming, yes, it's peach and it's not hot pink. Or yes, it's green and it's not a pale green. All right, we hit on diet and making sure we confirm vitamin K. Vitamin K in diet, we'll talk about that. I think Chelsea has that in her lecture a little bit tomorrow, so we'll talk about it some more. Pregnancy, so obviously probably doesn't fit with this particular patient, but it's category X in pregnancy. We'll talk about that. Also drug interaction, I want to say it's a couple weeks from now. But pregnancy, making sure we avoid warfarin in pregnancy is really important. Why would we give a patient who's of childbearing age warfarin? What kind of disease state are we worried about for those particular patients? This patient has AFib, right? So, you know, a 28-year-old female is probably not going to have AFib, but what could they have?
You could have the Leiden, factor 5 Leiden.
Yeah, they could have genetic differences, right? There's some of our genetic differences that cause prothrombotic states. Good. What else?
DVT.
Yeah, DVT or PE, right? So they do. You could have a risk factor. You could have a patient who has a DVT, PE, and is started on warfarin for that. Good. And then most of the time with my warfarin patients, I typically tell them to take it in the evening, and that's because they will have appointments usually during the day. So if they come in and their INR is high or their INR is low, I'm not going to adjust their warfarin dose. And it's much easier if they take it in the evening, because then they can change it for that day, as opposed to telling them, okay, change it tomorrow. So that's one little counseling point that I usually throw in, is to try and take your warfarin in the evening. Not that you have to, it doesn't really matter. Obviously the half-life is longer than 24 hours, so it doesn't matter in terms of our clotting factors. But in terms of me and ease of dose and communicating, it's a lot easier if they dose in the evening. All right, we are going to go over.
Dr. Misha, this is Sarah in Athens. Has the audio issue resolved?
Yeah.
Okay.
Are you good now?
Yeah, the Athens campus can respond to questions.
Awesome, thank you.
You're welcome.
All right, Athens, you're on the hook now. Cool. All right, so warfarin interactions, like I said, we're going to go over tomorrow. This is just a little snippet. I think Chelsea included most of these in her lecture for tomorrow, but we're going to go into a lot more depth, so ignore this slide for today. It is important to make sure we counsel our patients on misdosing too, so this is a good practical thing that we talk about in clinic very often. So when a patient misses a dose, we tell them to take it as soon as possible, as long as it's reasonable. But if it's the next day, don't double up. And then most importantly, to mark it on the calendar. Athens, now that you can talk to me, tell me, why would I want a patient to mark their missed dose on a calendar?
Missed doses can affect INR.
Fabulous, yeah, and it's gonna make your INR go up or your INR go down. If you miss a dose.
Down.
Great, yeah, your INR is gonna go down if you miss a dose. So knowing how many days away I am from that missed dose is important, because if they're a little low today, it could be because they missed a dose a couple days ago. All right, let's move on to case 2. Again, at like 5-ish minutes, we're running behind because of the technical difficulties. So let's take 5 minutes for the next case, case 2.
Do what? Did you say something?
Oh, I asked if Kendall had any food.
I have a granola nut bar thing.
Yeah, I don't want to take it from you.
Oh,
I'm fine with mooching off your kid.
I wasn't gonna eat it. So I was supposed to eat it before I worked out, but I didn't.
Which one, two?
Yeah.
What did she say?
Let's do it.
Let's do it.
Hello. Hello. So sorry.
Camera that's recording silence and a blank slide.
Crop me out. Crop me
I
out.
can't crop you out of the pictures.
Crop me out.
You know, I really don't want to do this.
I hate Wednesdays.
I just don't like her.
Kiddos.
What dose do we do for those numbers?
So annoying.
What's the indication? Anticoagulation.
Bridging.
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 Let me look it up on Lexicon.
We have like a clotting factors, protein C and protein S, you know? I looked that up yesterday and I wrote it down and I left my binder at home, so.
Lovenox. Let's see what it says here. Dosing. Where's bridging? Conversion. Conversion from unfractionated heparin to subcutaneous. What the? Doesn't tell me anything.
I don't know what you drawing. I'm trying to explain to my boyfriend why we have no parking. She called it a road.
Isn't it Saint Sebastian?
A road. This is Saint Sebastian's. He doesn't know what the road names are. I'm just trying to. A road.
Wow, I like the color choices. You should draw the parking lines too for added detail.
With all the spots.
Yeah.
And the middle median has to be shaded in.
Yeah, true.
Because you can't park there. Or you know what? We're going to make this a project. I'm going to post the power plant anyways. Like she did it, like she posted the insulin one. So I'm sure she'll post this one.
What are we gonna be tested on for this class's exams?
Probably cases like that.
So we just have to memorize everything?
Alright guys, Savannah tells me this is a hard case, so we're gonna walk through it together. And it's a hard case because you probably touched on this in therapy, but you didn't have the time to go through it all with me. Oh no. Are you kidding me? This is like brand new batteries.
Are you kiddoing me?
We can still hear you. She's like, these are like brand new batteries, but I can still hear you, so.
Isn't there like a straight line option so you don't have to draw?
She's making full use of her pencil, okay?
Yeah, do that. It's very valuable.
Can you all hear me in Evans? Y'all hear me?
Yes, I can hear you.
Okay, thanks. So today is like cursed because my batteries just run out. so we're gonna see how long my new battery lasts. All right, Athens can hear me, Augusta can hear me,
Yes, ma'am.
Albany can hear me? Okay, good. All right, so Savannah tells me this is a really hard case and that you guys have not had this a lot. So we're gonna walk through the case together.
Alrighty.
All right, so last year in pharmacotherapy, you were probably introduced to the concept of bridging. So the concept of bridging is that for some reason we need to stop warfarin. In this case, we're stopping the warfarin because the patient's having surgery, correct?
Yes.
However, is this patient at risk for having a clot? And if this patient is at risk, why would they be at risk?
Yes, they are at risk. They just had VTE in the previous month or prior history of recurrent VTE during anticoagulation therapy.
Good. Good. So this patient clots all the time, and if we stop anticoagulation, the patient is just gonna clot right back up, which can be dangerous, all right? So then the question is, so we know that we want to bridge this patient, but let's go back a couple steps. So first we gotta figure out why are we holding warfarin and what's going on with that. All right, so we know the patient has a surgery, so we do want to hold, right, for that surgery. We don't want them to bleed through the surgery. So when are we going to have the patient hold? And why would we have them hold for that many days? Augusta, can you tell me how many days you want them to hold? And why do they have to hold for so many days with warfarin?
4 to 5 days prior to the procedure due to the half-life to get the INR back to normal level.
Good. The half-life of what?
Warfarin. Warfarin.
Of warfarin or something else?
The clotting factors?
Good. It's not the half-life of warfarin. It's not the half-life of the drug. It's the half-life of the physiological response that happens when you give the drug. So we're inhibiting the clotting factors, right? We're stopping the clotting factors. So it's actually the clotting factors that have a really long half-life, not warfarin itself. Does that make sense? I think I alluded to that in the last case, and I said warfarin, but really when we talk about warfarin and warfarin's long half-life, we're not talking about the drug, we're talking about the drug's effect. So that can get confusing because a lot of times we'll just say warfarin and its long half-life, but we're not actually talking about the drug. We're kind of making an innuendo for the clotting factors that it affects. All right, so 5 days is good, and we're doing it with the clotting factors. Let's kind of walk through the process of what you do when you bridge. So I think this is the piece that you probably didn't have in pharmacotherapy, or maybe you had it and kind of breezed over it. We're also going to kind of breeze over it because it's a complicated concept, and usually pharmacists do handle this a lot because we work a lot in community clinics, but typically you get further training, and you'll get more of this probably on your APPEs. So we're at least going to touch on it so you get the concept, so that way when you go onto your APPEs or you see this in the future somewhere, you'll kind of be like, oh yeah, we talked about that, or at least I kind of know where to go and what to think. All right? So the first step is to stop your warfarin 5 days in advance because of those clotting factors. We'll hit on that a little bit more in a second. So you stop the warfarin altogether at 5 days. Then you initiate your low molecular weight heparin. Casey, ask your question. Casey has a question.
How do we know what to bridge with?
That's a fabulous question. Casey's question is, how do we know what to bridge with? Like, why did I just magically choose low molecular weight heparin? I chose low molecular weight heparin because that's what we've historically used to bridge. However, given the half-life of the DOAC, that was your other comment, can we not use she was talking offline, why can we not use a DOAC? And that's actually a really good thought because they have a really short half-life, right? So just like low molecular weight heparin has a short half-life, so do DOAC. So there is some thought, and sometimes I have seen it clinically, where we'll bridge with a DOAC, like if a patient absolutely refuses to inject and they won't do it, and heparin, low molecular weight heparin enoxaparin is super expensive, and sometimes we can get a hold of, a little bit of DOAC here or there, so I have seen it. But typically we use low molecular weight heparin. but to be determined in the future, do we use DOAC for bridging instead of using low molecular heparin? So it's not completely unheard of for that to happen. So if you see that when you're out on rotation, don't be surprised. It's kind of like this off-label thing that people do, all right? But if I'm gonna start bridging, no matter what I'm gonna bridge with, I'm gonna start with 3 days before, okay? So we talk about half-life of clotting factors. We'll talk about this, I think it's on the next slide, or maybe a couple slides. You start to have your, when you come off of your warfarin, then you're starting to have a little bit slow rise in the clotting factors coming back. So you give it a couple days. It's going to take them at least a couple days to start to come back after you knock them out. So we have at least a couple days where the patient actually doesn't need any therapy. They can just be off of warfarin and not start another anticoagulant back. So in other words, your INR is starting to drop during that period. So if their INR goal is 2 to 3, then their INR is probably dropping definitely closer to 2 or slightly under 2, where they still have this little bit of coverage for a couple days. All right, and then 3 days prior, we're going to start the low molecular weight heparin, and then we're going to stop that low molecular weight heparin at least 24 hours before the surgery. So we'll go through a calendar in a little bit, and it'll make a little bit more sense, but hold that thought of 24 hours before the surgery, stop your low molecular weight heparin. So you're going to start your warfarin back 12 to 24 hours after the surgery. So essentially right after the surgery, you want to get that warfarin back because it's going to take 3 to 5 days for that INR to start to build again. So you want to get that back in their system as soon as possible. That depends on bleeding risk. So if the patient is really high bleed, then you would wait till that 24 hours. If the patient is not a bleeder at all, and they don't have any risk of bleed, then you start it more towards that 12 hours. And then you'll wait a whole day and start your low molecular weight heparin back, okay? So they do have this little period where they're not really on anticoagulation, and there is some risk of clot during that little stint, 24 hours or more, that they technically don't have any anticoagulation on board. They won't have any low molecular weight heparin. That's all kind of gotten out of their system, and haven't quite built up the rest of their anticoagulation again. There's a little risk period when you bridge. Questions about this little timeline I've presented here? All right, let's walk through it a little bit more and talk about the clotting factors like I was discussing. So when we are talking about warfarin, if you've done your pre-lecture for tomorrow's class, you will think about your clotting factors 2, 7, 9, and 10. And then we have protein C and protein S. So Albany, tell me what is the point of protein C and protein S? What does it do in the body? Albany, what does protein C and protein S do? If clotting factors clot, then what does protein C and protein S do?
They unclot.
Yeah, they unclot. Very good. Yeah, they're natural anticoagulants, right? They naturally unclot, right? So we have this balance naturally in our body of stuff that clots, makes us clot, and stuff that makes us unclot, right? And when we use warfarin, we're knocking out all of that. We're knocking out both our natural way to clot, which is a good thing in terms of our patient here, but we're also knocking out our natural ability to unclot. So we need to have this balance, especially when we bridge, because we're trying to balance this clotting and unclotting. And as you can see, the half-lives can be very, very long. So that's where we get the 5 days of holding. So if we look at prothrombin has a really long half-life. We think of half-lives, 3 to 5 half-lives, right? And then we get the full effect of something. So in 3 to 5 half-lives, it's roughly, very roughly, 5 days-ish. Okay, so that's where we get our 5-day hold. All right, so when we look at the calendar, we said that the patient is going to have surgery 2 weeks from today. So today is September 19th. I'm glad I figured out this calendar appropriately. Let's see if I did. Okay, today is September 19th, and they're going to have their surgery in 2 weeks, which makes their surgery be on October 3rd. Okay, we said that we want to hold them to hold 5 days prior to that. So if we're looking at the calendar, we look at October 3rd and we count back 5 days. So October 2nd, October 1st, September 30th, September 29th, September 28th is going to be the first day of hold. So their last dose then is going to be September 27th. So on September 27th, they're going to take their dose that evening before they go to bed. They're going to take their dose. And then on September 28th, they're going to take nothing. Okay? They're not going to take their warfarin. They're not going to take their Lovenox. They're just going to take nothing. Okay? And then we said we're going to start low molecular weight heparin, the Lovenox, 3 days prior, right? So we start with our surgery date. We count 3 days back. That's September 30th. So on September 30th, they're going to do their low molecular weight heparin. I chose it, BID dosing here. So since it's BID dosing, they're going to take 1 in the morning and 1 in the evening. Okay? Then we said they're going to stop their low molecular weight heparin 24 hours before the surgery. I always assume their surgery is going to be first thing in the morning because surgeons like to cut people really early in the morning. So typically most surgeries we try and put earlier in the day. So then I don't give them their evening dose because that would be, if they're going to have their surgery early the next morning, then that would put them too close to the surgery if they took that evening injection. So the night before, they would skip their Lovenox because you want a full 24 hours. Okay? Or close to 24 hours. I guess it doesn't have to be exact, but close. Okay? And then we would maybe start to work from back on October 3rd if it's cool with the surgeon and he's like, yeah, she's not bleeding everywhere, good to go. And then they would possibly restart their low molecular weight heparin back the day after. Okay? They would start warfarin on the afternoon of the surgery. So if they had surgery in the morning, they would restart their warfarin that evening, and then they would start low molecular weight heparin or Lovenox the next day. Because you'd wait 24 hours after the surgery. Okay? But that low molecular weight heparin starting Lovenox back is based on their bleed risk. So it could be a couple days before they start their Lovenox back, depending if they're bleeding, not bleeding, how big is the surgery, what's going on during the surgery, did they bleed during the surgery, all those types of things. And then we would continue the enoxaparin until they become therapeutic on their warfarin again. Okay? So I didn't include all that, but yeah, eventually you would stop the Lovenox once they're therapeutic on their warfarin again. Okay? So we would see them a few days after starting their warfarin back. Probably 3 to 5 days after they started their warfarin back. And we would check their INR. If their INR is therapeutic, then okay, we're good. Typically. It's kind of like restart, like you would do with warfarin start. You would give them a little bit of time, make sure their INR is therapeutic. All that stuff. Okay? All right. What questions do y'all have about what we just walked through? I know this is a concept you haven't seen before, so I want to make sure that you don't have any questions before we move on. All right, so let me directly answer the questions in the case for you so that you have them. So question number one, how long should the patient hold? That's 5 days, and it's based off their clotting factors. What date should she begin to hold? That's 5 days. That would be the 28th because the surgery is on the 3rd. How would you recommend holding? Oh, you skipped this. How would you recommend if it was a DOAC instead of warfarin? So when we think about DOAC, we think about different half-lives, right? So now we really are worried about the half-life of the drug and not worried necessarily about the half-life, the physiological half-life, like we talked about the clotting factors earlier. So when we think about DOACs, we're really thinking about what is the half-life of the drug, okay? So when we think about half-life of DOACs, they're relatively short. So when we hold with DOACs, then we will hold somewhere between 48, 72, sometimes 24 hours, depending on the risk of surgery, depending on which DOAC we're using, all of that stuff. So typically 48 to 72 hours, but it could be 24 hours if you have like a really low risk bleeding surgery. So Casey, that goes back to your question about can we use a DOAC? Yeah, actually we can. It kind of depends. But if it's a DOAC with a longer half-life and we have really high risk for bleeding and we're trying to not hold, then it doesn't make sense to use a DOAC because the half-life, if we think about holding for 72 hours, then we wouldn't use a DOAC because that's like basically taking nothing, right? That's 3 days before. So a DOAC we typically hold usually 48 to 72 hours, could be 24 hours if we have really low risk of bleed. Okay? Question 4 on your case is, does the patient need to bridge with enoxaparin? If so, how are we going to start it? What are we going to do? We said yes, this patient does need to bridge. We said they need to bridge because they are high risk, because they've had a VTE in the past and recurrent VTE, correct? What dosing are we going to do for Lovenox? That's something we didn't touch on.
1 milligram per kilogram BID, which would be 62 milligrams BID for her sub-Q.
I like that idea. Okay, so you did BID too. So 62 is kind of a weird number for Lovenox. So typically we'll round to the nearest 10. So if we were going to round that to the nearest 10, what would we round to?
60 milligrams?
60, yes ma'am. Yep, 60. So we would do 60 BID. You could also do once daily dosing. So if I did once daily dosing, what would my dose be?
Uh, 120 milligrams?
How'd you come up with that?
I doubled it.
So not correct. Somebody else help her out.
I doubled
60 BID if I'm going to do twice a day dosing. Tell me again, whoever said 60 BID, what was the math that you used to calculate 60 BID?
It's 1 milligram per kilogram.
Good. So if we're going to do weight-based dosing, we do 1 milligram per kilogram twice a day. Or we can do 1.5 milligrams per kilogram daily. Okay? This is most important dosing, or everybody in the whole class. I want you to take a piece of paper and a pen, and I want you to write this dosing down. Okay? When you dose Lovenox therapeutically, write this equation down. Like literally write it down. Like nobody's sitting that's moving. I'm very serious. This is like one of the most important things you're going to do on your 4th year rotation. So you're just going to start your 4th year rotation notebook today in class right now. So, Athens, I don't see you moving. I can't see Albany and Augusta because they're facing the wall. But literally, everybody wants to take out a piece of paper and a pen and write this down. Or if you have your laptop on, you can take it. You're about to start your APPE notebook right now in class today. This is so exciting. All right. When you're dosing Lovenox, this is a memorization. This, I promise you will be on the test. I promise you this will be on every anti-coag, anything you ever see from now on. This is the most important anti-coag thing you could possibly ever know. When you dose Lovenox, therapeutic dosing for Lovenox, okay? Now I'm going to make sure I don't mess it up. 1 milligram per kilogram. 1 milligram per kilogram, twice a day. Or you can pick to do 1.5 milligrams per kilogram daily. So whoever just doubled it and said take 120, you just killed your patient.
Oh, thanks for telling Bonnie she killed the patient.
We're gonna get to do this more tomorrow too. We have some like fun graphics tomorrow. Not tomorrow, sorry, next week. Next week. All right, everybody's got that written down. Okay. I skipped the slide, so let's talk about the slide that's in front of me, so I cannot skip it. All right, when we talk about DOAC and holding, we talked about half-life.
Is her mic dead?
Thank God.
Your mic died, we can't hear you.
Who said that?
Who said that?
Yes, Sarah.
Hello?
Lady.
If we all left, she would literally have no idea. Besides the fact that no one would.
Dr. Risher, are you going to give us this PowerPoint after this class? Because that would be super helpful.
Super helpful.
Yeah, we can hear you.
Okay, cool. Alright. We are gonna fire out batteries. Like everything Alright, so we talk about
Your volume is really low in Athens.
y'all turn your volume up.
Sorry, we're having a hard time hearing you in Athens.
Can y'all hear me at the other campuses or just Athens?
We can hear you in Augusta.
Athens, can you turn your volume up in the classroom?
You're good now.
Okay. Alright, so when we talk about DOACs and holding DOACs, we already talked about half-life is important. When we talk about drug interactions, we'll also go through renal adjusting for DOACs. We think about bleeding risk, obviously, and what's the patient's risk for bleed. And then we can technically look at some drug assays and anti-10A levels and 10A levels in general, but we don't typically do that. But it technically is there and is an option. Alright, we already talked about a lot of this. When we bridge, we talk about what is our bleed risk versus what is our clotting risk. So when we think about bleed risk, we think about the surgery, we talk about has bled, we think about are they on antiplatelet agents for some reason, and if we can we just delay the surgery, because then obviously we wouldn't have to hold. When we think about clot risk, we think a lot about indication. So we talked about in this case that the patient had a recent clot, so that makes them more prone to more clots. So we get a little bit weary of bridging and doing crazy stuff when the patient's at really high risk for clot. But in this case, we didn't really have a choice because maybe of the type of surgery that she was going to have. All right? And then we think about the timing of discontinuation. So most of the time, like we said, it's 5 days. I have seen some docs every once in a while, they'll get a little, especially like this type of patient, where the patient has a high risk for clot. They might decide to only hold the warfarin for 3 days. I've especially seen that type of stuff around colonoscopies. A lot of times they don't like to hold for colonoscopies and things like that. So a lot of times I'll see some different holding patterns for colonoscopies. But in general, we think about 5 days. Dun, dun, dun. This is what you all should have written down on your papers, right? So when we think about therapeutic, we think about 1 milligram per kilogram twice a day. Or what? Right, 1.5 milligrams per kilogram daily. So we have to figure out is are we treating our patient therapeutically or are we treating them prophylactically? So So in this case, we were talking about therapeutic because the patient was already on warfarin, we're already treating them, we're already anticoagulating them. In other cases, we might just be doing prophylactic. So if we're doing prophylactic, then we usually think about 40 milligrams per kilogram, or maybe 30 milligrams per kilogram BID. Okay. All right, we are going through the case. Back to the case. So we answered the question through question 4, right? So question 5, why is bridging necessary when holding warfarin? And it's because of the half-lives of our clotting factors and also the clotting, also protein C and X. So protein C specifically has a shorter half-life. So the shorter half-life, and that's our natural anticoagulant. When we start warfarin back, we're worried about that. Okay? So protein C as well, protein S, and the rest of the clotting factors all play into why we have to do that bridging. Okay? We technically have a prothrombotic state whenever we start warfarin back. So especially after the surgery, we have risk for a clot. Okay? And then we said if this patient had AFib, how would our recommendation change for anticoagulation? So if we did a CHADS-VASc for this particular patient, our CHADS-VASc comes back at 1, I do believe. So if their CHADS-VASc is 1, they're at low risk for clot, and we may not have to bridge at all. Okay? So the reason we bridged in this case was because it was VT. All right, on to case 3. If y'all work on case 3, literally like 5 minutes, because now we're really running out of time.
Oh, gee, I wonder whose fault that is. I'm sorry. I'm so sleepy now. Huh? I'm in the newsletter? What newsletter? What?
Dr. Misher,
here in Albany.
Go for it, Albany.
Can you explain the answer to number 5, just because we're a little bit confused in terms of what you were talking about with the half-lives of protein C and S?
All right, absolutely. Okay. So if you look at the half-lives, right? So we have our, especially protein C. So protein C has a very short half-life versus your clotting factors tend to be a little bit longer. And you really have to like knock out multiple clotting factors in order to stop clotting. So we have one, factor 7, that has like a really short half-life, but in general we think about clotting factors have longer half-lives as compared to your protein C specifically, okay? So if we have, so when we start warfarin back, especially when we're starting it after the surgery, then we're worried about those first few days because you start to knock out protein C. Protein C is a natural anticoagulant, so you're knocking out your anticoagulant, putting your patient at a prothrombotic, putting your patient at a prothrombotic risk, especially in the first few days after starting warfarin back.
Does that make sense? Yes.
Good.
I think we have listed them. You just want to add some side effects like what? Especially
Did all your clothes come in? They delivered today. Oh. Exciting. I'm just thinking he's sleeping. Yeah.
your boyfriend say to the picture?
He said, "Fan with some impressive cartography." And then he said y'all should petition to have that lot turned into a farm only lot because having that many people being allowed to park in that smaller lot is absolutely.
All right. Okay. So again, we're getting some concepts here. I think that you maybe touched on pharmacotherapy, but didn't do very in-depth in pharmacotherapy. So I'm gonna help walk through cases again. So I specifically picked cases where you guys kind of get the kind of underlying concepts of anticoagulation. And for this class, I want to make sure we take it to kind of the next level and really think about if I was on rotation, what would I be doing right now? Just to confirm, can you hear me in all the campuses? Athens, can you hear me?
Yes.
Augusta?
Yes, ma'am.
Thank you. Albany?
Yes.
Okay, good. All right, so I purposely, just like last week, I made it challenging. This week I made it challenging on purpose too, because these are real world situations. So you guys got the pharmacotherapy last year for both diabetes and anticoagulation, kind of learned the basics, and now we're really starting to apply it. So as you can tell, when we start to apply concepts, things become complicated pretty quickly. And in the real world, things are not as easy as they seem sometimes in pharmacotherapy. So it's not just about memorizing a dose and spitting the dose back out. It's really about being able to go into your patient, think through what's going on with this and what am I going to do about it, okay? So I fully anticipate that you guys don't know how to do all these cases, and that's why we're doing them. So I know it's frustrating, but I'm kind of doing this on purpose, because these are the situations you're going to face both next year when you're an API as well as when you're a pharmacist. You're going to get these types of questions. Hey, I have this patient. This is what's going on. What do I do about it? And what I want you guys to do is figure out some resources and things to be able to think through these questions and figure out what are the most important concepts that I need to draw from each of these cases. All right, so we're just using anticoagulation as a way to think through how do I deal with really complicated situations. All right, so the ways that I deal with this type of situation is a lot of times you can go to a package insert and it gives you a lot of information about how do you switch from one med to another when it comes to anticoagulation. So I put this table together. You don't need this table. The reason you don't need this table is I would never expect you to memorize this table. I put it together to show you that all of this data exists.
Dr.
Most
Phillips.
of the time it's in the package insert. So when we're switching from warfarin to a DOAC, then we would follow the recommendation based off whatever DOAC we're going to. So typically when we're starting from warfarin and we're going to other DOACs, typically we wait until the INR drops a little bit. So making sure the INR is less than 2 or less than 3, because you don't want them to be doubly anticoagulated, right? You don't want them to be too thin and have bleed risk. So you let their INR drop at least a little bit, and then you start the DOAC and you just let the warfarin go. So you don't have to taper or anything crazy. That doesn't make sense, right? So we just stop the warfarin and we start the DOAC, but we at least let their INR get down a little bit before that happens. Does that make sense? Okay. So this is how we real world, these are real life situations, this is how we would do it. What I would do is I would go to my favorite drug information source. So I would go to either Lexicom, or I would go to Micromedics, or I would go to Fast Comparisons, or in this case, I would just go to the package insert, whatever it might be, and I would look it up every single time. I don't memorize this information. I don't memorize it on purpose because I don't do this very frequently. So because I don't do it frequently, I want to make sure I get it right because this is high stakes. So I look it up with the answer. Okay? All right, and then how would your recommendation change if you're going DOAC to DOAC? When we go DOAC to DOAC, we have a few things to keep in mind. Primarily, we want to think about what is their renal function and how does their renal function matter in this case, because DOACs are cleared renally, right? So we want to make sure that we adjust for their renal function, and it all kind of depends what's going on, but most of the time with DOACs, you can switch 1-to-1 because they all relatively are fairly close. If we're going from DOAC to warfarin, then we may keep the DOAC on for a few days, okay? So then, Casey, back to your point, then your DOAC becomes kind of like your bridge. I have air quotes on for other campuses that can't see me. I'm air quoting that the DOAC kind of becomes a bridge while you're starting with warfarin, because Albany, you have that protein C that you're going to cut out quickly with warfarin, so you want, if you can, that bridge is kind of nice for a few days, so that you can get them through that pro-thrombotic state when you first start warfarin. Okay. What questions do you all have about changing from warfarin to a DOAC, DOAC to a warfarin, or DOAC to DOAC? I realize this is a new concept. Hearing nothing, I'm going to move on. All right, so we already talked about phonetics and all that. So when we talk about DOACs, how much of this did you get in therapy? My guess is maybe a little, but not much. And when you did it in therapy, you probably saw there's a drug. I adjust it based on renal function and some other parameters depending on which DOAC it is. But maybe didn't go into a whole lot about counseling. They get head shake. Yes, right? So you realize that these drugs exist, but what's different about DOACs is that there are some specifics from each DOAC to DOAC. And these are really important when we think about how are we going to use these in our patients. So for next week, we are going to deal with this a little bit more, because we're going to do a choose your own adventure. And y'all get to pick what the patient's going to go on, and we're going to do some exploring. But I wanted to hit some highlights today so that next week y'all can make educated decisions when you're choosing therapy pathways for your patients. All right, so we're going to start with apixaban. And in terms of apixaban, we have some pearls to think about, or some things to think about. And that is that typically we adjust the dosing based on a few different parameters. So it's not a one dose and done. We have to pick the dose based on what the indication is, what the patient's age is, their serum creatinine, and their weight. So all four of those play into which dose of apixaban you're going to pick for your patient. So anytime you think apixaban, think I have to do some adjustments based on different parameters. My parameters for apixaban, indication, age, creatinine clearance, and weight. And typically for apixaban, it's twice daily dosing, which can make it a little bit more cumbersome. But think about BID dosing, right? So that's markedly different from warfarin. Warfarin is once a day dosing. Apixaban, really short half-life, right? So BID dosing. Okay? All right, when we think about rivaroxaban, we are going to talk about this a little more in drug interactions, but we have to take rivaroxaban with food. Our dosing, again, is different based on indication, renal function, and weight. So notice here that rivaroxaban is not different based on age, like we saw with apixaban. So apixaban we dose based on age as well. Here, all we have is indication, renal dosing, and weight-based dosing. Okay? This is all packaged insert information, Lexicon information, stuff you can look up. Okay? But realize that those three factors are really important for dosing. Ashley, go for it. Ashley has a question here. Savannah, use your mic. No questions are done. No, use your mic.
So for these DOACs, you don't have to measure INR or like go to a clinic, right? So when we just want to use this, it seems a lot easier.
That's a fabulous question. So yes and no. So no, we don't have to monitor INR. We don't monitor INR for DOAC because it's a 10A inhibitor, right? So we're not targeting the same target that we do for warfarin. We're not measuring INR. Okay. So technically, we can do some 10A assays for these, but we typically don't. So in terms of monitoring the actual drug itself and its anticoagulation properties, we don't do a whole lot of monitoring. So these typically, I'm going to put some air quotes around that, but typically we don't do a lot of monitoring of the anticoagulant effect of DOAC. So yes, that does seem as if DOAC would be much easier to use. However, as we just said with apixaban, rivaroxaban, we'll talk about this with dabigatran and all the rest of them, right, edoxaban, you do have to monitor their renal function, their weight, their age, and I guess indication isn't gonna change, so you don't have to really monitor indication. But you do have to monitor renal function for sure, weight for sure, and then for apixaban, like we just saw, age. So it's age adjusted. So although we don't bring them in like we do for warfarin, pharmacists specifically have gotten really involved with DOAC monitoring, because that's what a lot of times they're marketed as, like, oh, you don't have to monitor it, they're so easy to use. But what we found is that patients are still at risk. They're at risk for non-adherence. If you're not adherent, you have higher risk of clot, right? So apixaban, like we just talked about, was twice-a-day dosing. So if you miss a dose, you're at risk for clot. It's a really short half-life. You miss one dose, you could clot, right? So there's lots of education needed, and there's lots of monitoring, especially in terms of renal function, weight, and age. So yes, we do typically bring these patients back. We usually bring them back 3 months after starting, depending on the patient. A month to 3 months after they start, definitely check their renal function. And then depending on the stability of their renal function, then we might bring them back every 6 months or so, really checking for adherence issues at that point, as well as renal function. Really good question. Really good question. That's a really good question because the way that these drugs have been marketed, these drugs have been marketed specifically to be the opposite of warfarin, not having warfarin clinics and not having patients being monitored all the time. But what we have found is that we do have to do some monitoring, and it is important for us to still be involved in making sure that happens. So literally now you have anticoagulation clinics that are focused around monitoring of DOACs. It's different, but we still do it. Okay. Really good question. All right, let's move on to dabigatran. So dabigatran, you have to take a full glass of water. So that's a good point to note that you can't just take it like with a little splash of water. You have to take a full glass of water. Okay. Of the DOAC, this is the one with probably the weirdest side effect, and that's usually that it causes some nausea and some bloating, and sometimes people don't like that. So if there's going to be a DOAC with a notable side effect other than bleeding, it's probably dabigatran. Okay. You also have to store this in its original packaging. Okay. Dabigatran you have to put into your original packaging, so you can't put dabigatran in a pill box. It has to stay in its original. Do y'all learn this last year? Did I get some head shakes there? Cool. So you cannot put dabigatran in a pill box. It also is twice-a-day dosing, which can be cumbersome.
Doesn't this one also have a reversal agent?
Absolutely, yeah. So dabigatran does have a reversal agent that's on the market now, and the other ones will have an agent soon. I don't think it's been yet, but soon, hopefully, soon. Okay. But that is dabigatran's big selling point, is we have a reversal agent for dabigatran. That's a good point. All right, edoxaban is our next one. So edoxaban, it's nice because we don't have regard to booze. So rivaroxaban, dabigatran, we had specific recommendations for what you have to do around food. Edoxaban doesn't have that. Again, we think of our big ones, right? Renal function, just the dosing adjusts based on renal function and weight. And we do have some interaction with PGP inhibitors as well. So this one is a little bit different, especially in terms of renal function and AFib. So most of the time we think about there being a problem when they have low renal function. This drug actually has a problem when there's really high renal function because you get rid of so much of the drug that you don't have enough in the system. So if they have a really high creatinine clearance, edoxaban is probably not your drug of choice. So your young, healthy patients, edoxaban is not your choice because they have really good renal function. They'll get rid of the drugs. You'll have too low concentrations, and then you have risk for clot. I don't expect you to memorize dosing. I just want you to get the big concept. All right? Let's hit the last one. So this is our newest to market. Vitrixaban is really just used more in the inpatient setting, and we really use it for VTE prophylaxis. This is kind of changing and it's getting more indications as it goes along, but for right now, this is typically where we use it, so it doesn't get a whole lot of use. but the dosing can be a little tricky. Again, I don't expect you to memorize dosing, but the dosing is a little tricky, and we have to take it with food. So if we're thinking about we're using this in an inpatient setting, and then we have specific dosing that's kind of wonky, and then we have to take it with food, that kind of really limits our use of this particular medication at the moment. We'll see what happens in the future, but for right now, we're kind of like, most people put a little bit of a hold for the moment. Okay? All right, we already talked about renal, monitoring renal function, also hepatic function. We do monitor bleeding, obviously, for these. One thing that we really look for is the CBC, and specifically in the CBC, we look for platelets. So, Ashley, to answer your question, yes, we monitor renal function, hepatic function, mostly renal function, but also some hepatic platelets is what we really look at. Dramatic, something that you want to look at in the lab, platelets. Okay? Sometimes, as I mentioned, we can do, technically we can do anti-10A levels, but we typically don't. So, on 10A for right now. So we don't necessarily monitor the anticoagulant effect. So if you're monitoring 10A levels, we'd be monitoring the actual anticoagulant effect of the drug, but we don't really do that, to get to your point from earlier. With warfarin, we monitor the INR, so we monitor the anticoagulant effect. With DOACs, we do not monitor the anticoagulant effect, we don't monitor 10A. All right, let's pause. What questions do you all have about DOACs? All right, we're going to move on. We're going to talk about some unfractionated heparin. All right, so let's move to case 4. We're going to walk through case 4 together because I'm like 98% sure that you've probably never seen this before. So I want us to walk through it together so we can all be on the same page and I don't want you all to get super confused with different things. All right? Is everybody comfortable with moving to the next case? All right, hearing nothing, we're going to move on. All right, so case 4, we have Mr. Jones. We're actually going to do case 4 and case 5 together, okay? So case 4, Mr. Jones is a 54-year-old male. He was admitted for treatment of a PE, all right? So 54-year-old male, PE, and the team has ordered heparin for him, okay? Unfractionated heparin. Earlier, when we wrote down our numbers, let's be very clear, we are talking about low molecular weight heparin. In this case, we're talking about full-blown unfractionated heparin. Sorry about that. All right, patient has a past medical history of CKD. All right, patient has a history of CKD, hyperlipidemia, diabetes, hypertension. He doesn't have any allergies. Currently, he's doing amlodipine, atorvastatin, Lantus, aspirin, calcitriol for his kidneys. His vitals today, what did we say last time? They're beautiful. Is that what we call them? Beautiful vitals today. But he is in some pain, and we have his labs here. And we're going to consider for today, for these purposes, these labs were collected today, right now-ish. Okay? So in terms of timing, we're going to think of his labs as we're collecting them today. That's going to be important in the next case. So when you look at these labs, put it in today's date right here. Okay? All right, let's walk through what are we going to do for his heparin. Right? Because the team has asked us to start heparin. So on ELC, I've posted some heparin protocols for you. So if you go to ELC, and you go into today's lecture, part of your required reading for today's lecture was these heparin protocols. So we have a bunch of different protocols. The reason we have different protocols is, for one, because institutions vary quite a bit in terms of how they dose heparin, and also there's variations based on indication. So you want to make sure you're understanding what is the situation with your, sorry for the coughing, guys, I'm getting over a cold. The you want to understand what is your institution's protocol for heparin dosing, and then you want to figure out what is the patient's indications to make sure you pull up the right protocol. So I purposely put all these up here because it's very confusing, and I want you to realize that there's multiple ways you can dose heparin, right?
Oh my god.
So I'm going to walk you through one example to walk you through how do we do a heparin protocol. All right, so you guys, I know, have already looked at all these protocols because you did your required reading before the class. So this patient that we're talking about has a PE, right? So because they have a PE, we're going to go to this DVT protocol here, okay? So when we look at this protocol, it tells us the things that we're going to monitor up here, which is quite nice. And then it also tells us how are we going to dose our heparin. So with our initial bolus, this is the calculation, it's 80 units times their weight, and that gives us the number of units that we're going to use, essentially. Okay, so this patient's weight is 170 pounds. So somebody in Athens, tell me what is their weight in kilograms?
77.27.
Fabulous. So their weight in kilograms is 77.27 kilograms. So when we're thinking about the bolusing for this, we're going to look at our initial bolus is 80 units times their weight in kilograms. So we're going to do 80 units times the 77.27. Athens, tell me what that number is. 80 times 77.
I just want to sit down.
6,181.6.
Yeah. 6,180 or 60 or somewhere around in there. Typically, we'll kind of round to the nearest 100 for this. Sometimes you can round to the nearest 10, kind of whatever, somewhere in there. So I got 6,200 when I rounded. Good enough. Good. So then our bolus dose is going to be 6,200 units. Okay? Realize that we do have a max. So if somebody is morbidly obese, you're not just going to heparin them forever. There is a max of 7,500 units. Okay? So for this, we're going to round to the nearest 100 units, and it does have a max. So those are the two things to think about when you're figuring out your bolus dose. Okay, so we have this bolus dose of 6,200 units, and then we're going to figure out the infusion rate. So our infusion rate is 18 units per kilogram per hour. So then we take 18 units times their weight, which we said their weight in kilograms was 77. So if we do 18 times 77, Albany, tell me what that answer is. 18 times 77.
$13.86.
Right, yep, 1386, that's what I got too. And then we're going to round it, right? So 1386, we're going to round up to 1390. Okay, so in this case, we're rounding to the nearest 10. So then our answer is going to be 1390 units per hour. So our infusion rate is going to be units per hour. So 1390 per hour. And again, we have a max dose. So if we have a patient that's morbidly obese, then we are, or they're just a really, I guess they could be just really tall. Either way, if they have a significant weight, then we're going to limit their max dose. Okay? I'm going to pause right there. Any questions about the math to figure that out?
Not the math.
Any questions about taking a heparin protocol?
Dr.
You follow
Fisher?
your institution and you do based on indication. Go for it. Did I hear a question?
Yeah, we have one in Augusta.
Go for it.
How would we go about learning this information in terms of like testing material? Like, would you give us a protocol and we'd use that?
Yeah.
Like, okay.
I don't expect you to memorize this.
Well, I don't know.
Okay,
Yeah,
that's rude.
so I would ask you maybe some questions about it, but if I'm gonna make you calculate, I'm gonna give you the calculation.
Okay, thank you.
Yeah. So the calculations for last week with the insulin dosing and figuring out an insulin to carb ratio and figuring out an ISF, I'm not gonna give you that calculation on the exam. You guys have to know those calculations, they're pretty straightforward. But in this case, because heparin protocols are so particular based on institution, I'm not gonna randomly be like memorize all these millions of protocols and be able to spit them back out at me. I would give you a protocol and I would tell you what I want it done. Okay?
Yeah.
Okay. But here's something I will hold you accountable to. Let me go back to my slides real quick.
Oh my god. Why did I even ask?
All right. I will hold you accountable to some of this information. So what I want to hold you accountable to is more the PK/PD parameters and the monitoring for heparin. So when we think about heparin, it's really important to think about what the PK/PD parameters essentially and how we're dosing and how we're administering heparin. All right. So typically when we administer heparin, we either do it IV or we do it sub-Q. We no longer give heparin IM because of the erratic absorption from IM. Okay. So if we're going to pick a route, we do sub-Q or we do IV. Okay, typically most times we'll see IV. The reason that we don't do IM is because heparin PK/PD parameters are pretty variable, and so we don't want to add variability in the IM injection. So the bioavailability changes quite a bit with dose as you dose escalate. And depending on how much protein you have and all that, it can change. So from patient to patient, heparin dosing is very specific. So although we start with a bolus and we do that initial infusion dose, like I mentioned, that's going to be different. So those two calculations are going to be the same based on your protocol, but then you're going to have to adjust because of all these patient-specific parameters. So we start a bolus, we start an infusion, and then we adjust the infusion because of all these parameters of heparin. So as we start to adjust and the dose goes up of our heparin, the clearance goes down. So they're opposite relationship to each other. As the dose goes up, clearance goes down. So it's not a linear clearance for heparin. We have this non-linear clearance of heparin. So it makes things really wonky, and as you go up on the dose, you get less clearance, and it becomes really wonky. So that also emphasizes the point that we just have to do a lot of monitoring. Okay? All right, so let's kind of move on to a little bit more about protocols. And these are the pieces that I'm going to hold you accountable. As I mentioned, that we have weight-based dosing, typically for heparin, and it's based on indication. So making sure you're realizing that I could ask you a question about that. I probably will ask you a question about that. If you're to dose heparin, what you need to know? You need to know the institution's protocol. You need to likely know the patient's weight, and you probably need to know the patient's indication for heparin. When we monitor, I will hold you to this, that we monitor the APTT levels. I'll talk about that in a second, so hold that thought. But we monitor typically APTT, but we also do some monitoring for anti-10A, depending on the institution. So not all institutions at this point monitor for anti-10A levels, but there's some clinical controversy out there. Should we be monitoring anti-10A levels or should we be monitoring APTT? Anti-10A tend to be much more specific and less variable from patient to patient, so it's probably clinical controversy, but probably better of a marker. But currently, there's probably more institutions that do APTT monitoring of heparin. So we can do either one. We can do APTT or we can do anti-10A. Currently, most places do APTT, but some you may see in practice do anti-10A. Okay? Those adjustment recommendations that are in the protocols are variable from one protocol to the next. So it's based on your institution in terms of what adjustments you make. And also when to notify the physician is also variable. So it depends on your institution. So look at your protocol, okay? For your institution. All right, but in general, this is kind of what we do. Maybe I'll back up a little bit. So first, like I said, we have to monitor, right? So we start by obtaining an APTT, okay? So you get the patient's APTT at baseline. So that's key number one. Get their APTT at baseline. Start the bolus dose. Then, as you can imagine, right, and we do that, go back. On this protocol, we did a bolus dose of 80 milligrams per kilogram. Typically, that bolus is anywhere from 80 to 100. I'm not going to hold you to that, but somewhere 80 to 100, roughly. Okay? That's that bolus dose. At the same time you're starting the bolus, you also start the drip. When we do the drip, we do somewhere between 17 to 20. In our example protocol that we used, it was 18. But somewhere between 17 to 20 units per kilogram per hour. Okay? So we got their APTT, we got their weight, we calculated a bolus dose, we calculated their drip rate, we gave them both of those, and the patient's now on a drip. Then 6 hours later, after we started that process, we're going to collect another APTT, and we're going to adjust the dose based on that APTT. And the reason we're adjusting the dose is because of all those crazy parameters that change from one patient to the next. Bioavailability, enzymes, protein binding, all those types of things. Renal elimination, all those things are variable from patient to patient. So we get an APTT at 6 hours, and we dose adjust at 6 hours based on the APTT. And then we get another APTT at another 6 hours after that. For every adjustment we do, and change in dose, we get an APTT and adjust based on the new APTT. Or you can put anti-10A kind of in here as well, but for right now, the way I want you to learn it for now is just APTT. Keep it simple. Okay. What questions do you have about this slide in particular about adjusting heparin based on APTT? All right. So then our question is, what values utilized for monitoring heparin treatment, and at what point do we need to obtain the monitoring value? So we are monitoring the
APTT.
Augusta, tell me what we're monitoring.
Is that right? APTT?
Yes, ma'am. Very good. And we're going to do so at baseline and at 6 hours after we initiate therapy. And every 6 hours, after we adjust, change a dose, whatever it might be. Okay? You initiate both the bolus and the drip rate at the same time. The drip, yeah, bolus and drip at the same time. Check the APTT 6 hours later.
That's my highlight.
Okay? I think we've said this probably a million times. The protocols vary among institutions. All right, we do both of them at the same time, and we typically do IV, although we can do some sub-Q, but typically we do IV. We monitor the APTT, hard to say. And then as I mentioned, some do anti-10A levels, but not as popular, but probably becoming more popular. I guess I could say it that way. All right. So for the next case, it's the same patient, but now he's been on heparin for 5 days. They did his drip wrong, so he's been getting lots and lots and lots of heparin. We look at the labs, and there is a difference in labs. Specifically, what changed in his labs, I'll just give you the hint, and I'll just limited time because of our technical difficulties, his platelets changed. Okay? So his platelets changed from his first day to now. All right, so same patient on heparin, 5 days now. So key is 5 days. 2 is that his platelets have dropped. Okay? we go to the first question. First is APTT. You guys wouldn't know this yet, but APTT is super therapeutic. Makes sense, right? They put the drip rate on too high, his APTT is going to go up. So his APTT is too high. And as I mentioned, his platelets are low. Okay? So with the concept that I want to teach you about today is rare, but a possibility with unfractionated heparin. And that's HIT. Have you guys covered HIT at all in pharmacotherapy? You did. I'm getting some yeses. Okay, good. So I wanted to highlight a couple things about HIT. This is super rare. You may not see it on rotation, but you might. So I kind of wanted to bring your attention to it, because it's one of those things that doesn't happen very often. But if you have a preceptor on rotation and this happens, you'll be like, what's going on? And you're gonna be like, I'm super smart, it's HIT. So these are things to look for. When you think about HIT, it can be non-immuno HIT, or it can be immune-mediated HIT. So what we're gonna focus on for this case is immune-mediated HIT. And because you have to wait for the immune system to kick in and then start to attack, then there's a delay in terms of when you're going to see this happen. So typically, like this patient in this case had been on heparin for 5 days. So you're going to have a delay in this decrease in your platelet count, and that delay is going to be somewhere between 4 to 10 days after heparin exposure. Okay? So immune-mediated has a delay, and that delay is somewhere between 4 to 10 days. And the way you really find it is that the patient's platelets drop below 50%, which is what happened here. You have a 50% decline in their platelet function. Okay. With a non-immune-mediated HIT, then it usually happens quicker, and the platelets tend to recover. All right. And thrombocytopenia, going back up on the slide, we define thrombocytopenia as platelets less than 150. Okay? All right, so we got some thrombocytopenia. We're linking it to HIT, or to heparin, and we're saying it's immune-mediated HIT. Just a quick review from pharmacotherapy. All right, so when we find this to be the situation, then what we're going to administer in that case, we're going to stop the heparin, and we're going to switch it to argatroban. So argatroban is not a highly used drug, but most of our hospitals do still carry argatroban for this reason. So if you see a patient on argatroban, it's one thing to think of is, has this patient had HIT, or do they have HIT, or have they had HIT in the past? All right, so we're going to kind of skip through this in terms of argatroban PK, but it's there. The other piece I wanted to highlight real quick is heparin reversal. So we mentioned earlier that DOACs have reversal, warfarin has reversal, right? What do we use to reverse warfarin? Vitamin K, right? Yeah, good. Vitamin K. Nobody used their mind, but Savannah resoundingly all together in one hoarse voice said that we use vitamin K to reverse warfarin, okay? And we can also reverse heparin. So we use protamine sulfate to reverse heparin. Is this something you guys saw before? I'm getting like a some yes and some no, so maybe we didn't clearly understand this concept before. Maybe a little bit. We got a little bit in pharmacotherapy, but I wanted to review it again for you because this is something we also practically use out in the real world. So when we want to reverse heparin, we use protamine sulfate. And we use 1 milligram for every 100 units of heparin. This is a fairly straightforward calculation, so I will hold you accountable to 1 milligram of protamine sulfate for every 100 units of heparin. Okay, it happens really quickly, so we can reverse heparin real quick. That's why we use it. The way that we use it in inpatient setting is because it has such quick reversals. So it's really, really quick reversal. That's why we like heparin. We can turn it on, turn it off, turn it on, turn it off. Okay. All right. so let me make sure I answered all my questions. So number 3, for our, so let's go back to question 2. Does Mr. Jones' heparin infusion need to be adjusted? If so, what adjustment is recommended? And we said we're going to stop his heparin, and we're going to change it to ergatriban. And nobody memorized his ergatriban dosing, so we would look it up. I think is the way that works. And then question number 3, if Mr. Jones was experiencing a bleed, what would we do? We would reverse him with protamine sulfate, 1 milligram of protamine sulfate per 100 units of heparin. All right, I'm going to also walk. If I can talk, I'm also going to walk you through case 6. Because of our technical difficulties, this is what I wanted you all to do on your own. So I highly encourage you to do this on your own as well, and make sure you understand this case. Let me say that again. I highly recommend that on case 6, you walk through it yourself after class and when you're studying, because this is one I intended for you to do on your own, okay? But we're going to do it together because we only have 8 minutes of class left, and I had technical difficulties, so we didn't get to it. All right, so case number 6, 67-year-old female who was recently admitted due to pneumococcal pneumonia infection. She refuses to get up. She doesn't want to walk now. She's immobile, so she's not going anywhere. She's laying in the bed. She's just sitting there, okay? So she has a past medical history for hypertension and PAD. She has an sulfa allergies. An allergy to sulfa. It's been a long day, huh? Allergy to sulfa. And she has her current inpatient medication, aspirin, rosuvastatin. So apparently she must have hyperlipidemia too, right? Lisinopril, amlodipine, and we gave her some ceftriaxone for her pneumonia. Ask Dr. Bland if that's appropriate, because I can't tell you. So her vitals today are beautiful, beautiful vitals today. And then we have her lab. All right. So she's laying in the bed, not moving anywhere. So we are going to work on giving her some low molecular weight heparin because she's not going anywhere. So what is the patient's indication for initiation of low molecular weight heparin or enoxaparin is what we're going to use at this point. And what is the appropriate dose for this patient? All right. So in your little notebook that you started your API notebook today. We wrote down our enoxaparin dosing for therapeutic, and now we're going to write down our dosing for prophylactic. Okay? Because she's prophylactic, right? She has not had any kind of clot. She's just laying in the bed waiting to have a clot. Let me make that very clear. She has not clotted yet. She is laying in the bed, not moving anywhere, just putting her at risk for clotting. Okay, so here's our dosing. Prophylactic dosing. I'm going to hold you accountable for 40 milligrams per day, or 30 milligrams twice a day. Okay? So if I'm going to dose Lovenox, these are like, you should just memorize this. This is a NAPLEX question. This is, you can't get away from it. This is what we're going to do. Okay? There's a caveat to this, in that this patient has normal renal function. Okay? This patient that you're talking about now has normal renal function. And so we're using this dosing for normal renal function. Okay? So since she has normal renal function, she's not going anywhere, she's just sitting there. We're going to use 40 milligrams a day or 30 milligrams twice a day. Okay? If her renal function declines, let's skip that for right now. We're going to skip this for now. And we're going to go to renal adjusting of enoxaparin. I want you to write this in your little API notebook right now too. Okay? So if her renal function declines, is she old? She's not that old. But anyway, she has bad renal function. Her renal function declines, we're going to change the Lovenox dosing because Lovenox dosing is based on renal function. So for prophylactic, we're going to use 30 milligrams per day. So before we would have said 40 milligrams per day, we're going to drop that to 30 milligrams per day for renal dosing.
Can
And for treatment, we're gonna use 1 milligram per kilogram per day. So when we have renal functioning, we have non-renal functioning, we have a decline in renal function. Less than 30, your creatinine clearance is less than 30. That's another key point. That's at a creatinine clearance less than 30. You're going to do a dose adjustment. Prophylactically, 30 milligrams per day. Treatment-wise, 1 milligram per kilogram per day. Okay? All right, and then let's talk through some counseling points of enoxaparin as well. So when we think about adjusting or when we think about administering, we have to think about where we're administering. So just like we talked about insulin last week, you inject relatively the same places, except not so much in the arms and legs like we did for insulin last week. But this week for enoxaparin, it's really just that belly section. And it stay at least a couple inches away from the belly button. Okay, so really on the plate. This is where we like to do enoxaparin injection. We want to make sure the dose is appropriate, and by dosing appropriate means that sometimes you have to squirt some out. So the syringes don't come in all strengths. So based on your strength, you may have to squirt a little bit out. Okay. So I think her dosing ends up being, I calculated 70. I'll post the answers to this quiz, or to this case. But what I calculated her is 70 milligrams every 12 hours. So if we dosed her 70 milligrams every 12 hours, we have to take an 80 milligram syringe and squirt a little 10 out to get to 70. Because it doesn't come in 70. The dosage form doesn't come, packaging doesn't come in 70. All right. We talked about injection. Injection technique is just like diabetes last week. You put it in a 90-degree angle. In terms of storage and disposal, this is not something you have to keep in the fridge, but you do want to teach them how to get rid of their sharps appropriately. And then you do want to teach them about signs and symptoms of bleeding, just like you would for any other anticoagulant. And we're going to skip on the Paranox because I'm not going to cover that. We have 30 seconds left. So, here's what we're going to do. Next week, we have a very interactive lecture. You have a post-class quiz for today. You have a pre-class quiz for next week. You must do the pre-class quiz for next week, otherwise you will not understand what's going on next week. Next week is a fully interactive lecture. So y'all are going to pick the therapies. Y'all are going to guide me in what we want to do, so I want you to be fully prepared. And it's a whole new different technology. You guys are going to use EHR Go. They're perfect. So you must do the pre-quiz for next week. Questions before I get cut off? From any of the other cases?
The pre-class quiz today?
Will you be posting slides? Post this PowerPoint.
I will probably post a subset of this PowerPoint.
A what?
Excuse me?
The what?
I'll post the last page.
Are you
You can go through it.
Someone say, please post the whole thing. Someone say, do it.
So no go on the entire PowerPoint.
No go on the entire PowerPoint. I feel like today I didn't mess up as much as I typically do. So, and I went over the most important points, I feel like very, very clearly. So I anticipated that you took appropriate notes and were interactive during the lecture.
You're doing cases.
We were just thinking that we would have this one as a reference, just because we don't really have a reference, other than
Say it again?
previous lectures.
Come again?
Can we request?
It would just be a better reference than what we have available right now.
Say it one more time, I couldn't hear you.
The PowerPoint that you have would be a better reference than some of the stuff that we have available right now.
You like my slides?
Yes,
Yes.
we
love
did.
them.
Yes, ma'am.
Yes.
All right, so I do this lecture in combination with Dr. Osei, and she's on maternity leave, so let me touch base with her and make sure she's comfortable, because these are our joint slides, and I don't want to post something that's not mine. They're both of ours, so I don't feel comfortable doing that until I have her approval, so I'll text her today.
Thank you.
Yes, ma'am. Other questions? All right, next week, I can't stress enough, do your pre-work next week. All right? It's gonna be really fun next week. I'm super excited to do your pre-work so we can have fun next week. We've been like super stressed getting through these cases the last 2 weeks. So that's gonna be fun with y'all. So, do your pre-lectures. Think about these cases that you did today, because these cases are gonna help you for the lecture next week. And come with questions at the beginning of next lecture, these past 3 weeks, because I know we did a lot. We did a lot of concepts y'all haven't touched on before. So I want to make sure y'all are very comfortable with what we covered. I very much understand that we did not do this in pharmacotherapy, and I want to make sure you guys are
Oh, it's
very,
unlimited
comfortable with
time,
the concepts
yes.
that we covered. All right? All right, I'll see y'all tomorrow, okay?